Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. I am Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we will talk about lumbosacral plexus, its localization. The lumbosacral plexus lesions are less common as compared to the brachial plexus lesions, and they are also not due to trauma. The traumatic cause is usually seen in brachial plexus lesion, but trauma is not an important cause as far as lumbosacral plexus are concerned. Why trauma is not an important cause for lumbosacral plexus lesion? It is because of 2 points. One, the lumbosacral plexus are well protected. They lie deep. Unlike the brachial plexus, which are very superficial, and therefore the brachial plexus are susceptible to traumatic causes, injuries. Whereas lumbosacral plexus are well protected, they are not superficial, they are deep, and therefore trauma is not a usual cause for lumbosacral plexopathies. The second important point is that the brachial plexus lies in a position between two movable parts, one the neck, second the hand, and therefore since it is in a fixed position between two movable structures, it is liable to traumatic injuries. Whereas in lumbosacral plexus, it lies between the abdomen, which hardly moves, and then the leg. There is not much movement. Since there is not much movement before or after the plexus, trauma is not an important cause of lumbosacral plexus. So trauma is an important cause for brachial plexus lesions because one, it is superficial, second, it lies between two movable structures, but trauma is not an important cause in lumbosacral plexus lesions because they lie deep and they are not between two movable structures. So this is a very important point. Yeah, now let's see how the lumbosacral plexus are formed. The lumbosacral plexus, as the name suggests, it's a plexus between lumbar plexus and the sacral plexus. I need to tell a very important point here. The lumbosacral plexus, if there's a lesion in the lumbosacral plexus, the prognosis is good and definitely better than the sacral plexus lesions. Why? Because when the lumbosacral plexus has a lesion in the lumbosacral plexus, the muscles which are involved are very proximal to the lumbosacral plexus, and therefore there could be axonal sprouting or proximal-distal regeneration of the nerves, and therefore the recovery is far better in lumbar plexus. Whereas if we take sacral plexus, if there is a lesion, the muscles, for example the gastrocnemius, is very far from the plexus, and therefore it has to travel a long distance to cover up the involved muscles. Therefore the proximal distal regeneration or the axonal sprouting, it takes a long distance for it to cover, and therefore the prognosis is bad for sacral plexus as compared to lumbar plexus. So the prognosis is always better for lumbar plexus as compared to the sacral plexus. In the lumbar plexus, the three important nerves are: one, the femoral nerve, second, the obturator nerve, and the third, the lateralcutaneous nerve of the thigh. The femoral nerve is formed from L2, L3, L4 dorsal divisions. It supplies the hip flexors and the knee extensors. The obturator nerve is formed from ventral divisions of L2, L3, L4. It basically supplies the adductors. Here again there is a very important clinical concept. How do we differentiate femoral neuropathy from the lumbar radiculopathy? Because femoral nerve and the L2, L3, L4, the muscle distribution is almost same, but when there is a radicular involvement, the muscles which are not supplied by femoral nerve are also involved. That's how we differentiate lumbar radiculopathy from femoral nerve lesions. So femoral nerve supplies the hip flexors, iliopsoas, and the knee extensors, quadriceps. But Femoral nerve does not supply the adductors. The adductors are supplied by the obturator nerve L2, L3, L4. So when there is a femoral nerve lesions, if hip flexors and the knee extensors are involved, but adductors are spared because adductors are supplied by the obturator nerve. This is one important differentiating point between femoral neuropathy and the lumbar radiculopathy. So this is femoral nerve and this is obturator nerve. Then there is another important nerve known as the lateral cutaneous nerve of thigh. It is formed from L2, L3. This nerve is important because a very common disease is because of this nerve involvement, lateral cutaneous nerve of thigh, which is known as meralgia parasthetica. That is, the thigh is involved. The lateral cutaneous nerve of thigh goes underneath the inguinal ligament, and therefore between the two planks of the inguinal ligament it can get trapped, and therefore there could be an involvement of the lateral cutaneous nerve of thigh under the inguinal ligament. So the sensory loss is in the anterolateral aspect of the thigh. The contributing factors are obesity, pregnancy and diabetes mellitus. So what do we suggest for treatment? We ask them to lose weight loss, and if they have an abnormal postures, to correct the abnormal postures, and if they have any tight wearing fitting dresses like belts or anything, we ask them to restrict the tight wearing or fitting the tight fitting dresses, loosen the tight fitting dresses. So this is about meralgia parasthetica. So it is caused by lateral cutaneous nerve of thigh because of the entrapment or getting compressed under the inguinal ligament. Anterolateral aspect of the thigh is involved. Diabetes, pregnancy and obesity are contributing factors. Weight loss, adjustment of postures and loosening of tight clothes are the treatments we offer for persons suffering from meralgia parasthetica. Alright. So this is about lumbar plexus, which is found basically from L2, L3, L4. We have the lumbosacral trunk, which is basically L4 and L5, and the sacral plexus is nothing but the connection between the lumbosacral trunk, that is L4, L5 and S1, S2, S3, S4. So this is the sacral plexus. When we come to the sacral plexus, the important nerve is the sciatic nerve. Sciatic nerve has got two branches. One, the common peroneal nerve, which is formed from the dorsal branches of L4, L5, S1 and S2, and tibial nerve, which is formed from the ventral branches of L4, L5, S1 and S2. Right? This is in nutshell the lumbosacral plexus. Now let's see what happens if these roots are involved per se, L2, L3, L4, L5 and S1. So now let's talk about radiculopathies, and then we'll go to the plexopathies. As we are aware that radiculopathies, when the radicals are involved, roots are involved, there's basically a shooting pain going around the dermatome. So a severe shooting type of pain going along the distribution of the root is the classic sign of the radiculopathies. So when the L2 is involved, basically the anterior thigh is involved. When L2 is involved, the sensory loss is in the anterior thigh, and if L3 is involved, the sensory loss is in the medial part of the thigh. The one reflex which is subserved by the L2, L3 and L4 is the knee jerk. So the reflex we can elicit if the L2, L3, L4 suspected radiculopathy is the knee jerk. So L2 supplies the anterior thigh, L3 supplies the medial thigh, L4 supplies the medial calf. It also supplies tibialis anterior muscle. This is one muscle we should always look for when there is an involvement, suspected involvement of L4 radiculopathy. The L5 supplies the lateral calf. It supplies the dorsum of the foot also, and the important muscles it supplies are the tibialis anterior for dorsiflexion, the inverter and the everter. It also supplies the gluteus medius, which is for abduction. It also supplies the hamstrings muscles. An important point to be noted is that there is no reflex for L5. For L2, L3, L4 we have knee jerk, but for L5 there is no definitive reflex. Then S1 basically supplies the plantar surface of the foot. It supplies the back of the leg. The reflex observed by S1 is ankle reflex. And basically the muscles are the plantar flexion, that is for the plantar flexion, gastrocnemius, and then the gluteus medius for the extension of the thigh. So how do we check the plantar flexion? Ask the person to bend of the foot. So for example, walking on the toes is plantar flexion S1, and for dorsiflexion L5, walking on the heels is L5. So easy way to check for L5 is walking on the heels, that is L5 dorsiflexion, and checking for the plantar flexion is walking on the toes S1, that is gastrocnemius. How do we check gluteus medius extensors? Ask him to lie flat supine. You just lift the leg and ask him to press down. So you are checking the gluteus maximus, which is supplied by S1. So gluteus maximus is supplied by S1, whereas gluteus medius is supplied by L5. So an important point to be noted is that L2, L3, L4, there is a jerk. So easily you can test out whether the radicals L2, L3, L4 are involved by knee jerk. There is no definitive jerk for L5. But if S1 is suspected, we can always check out on the ankle reflex, right? Now again, I am going to talk about an important clinical point, foot drop. So foot drop, as I talked about the femoral neuropathy versus the lumbar radiculopathy, now to differentiate foot drop because of peroneal neuropathy or the lower lumbar radiculopathy. So how do we differentiate? Peroneal neuropathy causes dorsiflexion weakness and therefore there is foot drop. It causes also everter weakness. Fine. But the inversion is done by L5, but it is the posterior tibialis supplied by the tibial nerve. So the dorsiflexion and eversion is done by the peroneal nerve, but inversion is done by tibial nerve. Though all the three are supplied by L5. So when you have doubt whether the foot drop is because of peroneal neuropathy or L5 radiculopathy, you need to test dorsiflexion and eversion, which are involved in peroneal neuropathy as well as L5 radiculopathy. But inversion, only L5 radiculopathy causes inversion defect, but not peroneal neuropathy, because inversion is done by tibialis posterior, which is supplied by tibial nerve. So very important differentiating point. Another differentiating point is that the peroneal nerve, the sensory supply is between the two digits, the first toe and the second toe. The width between the two digits is a sensory supply of the peroneal nerve, but for L4 it is the medial cough L4 and the L5 is the lateral cough. So by sensory findings also we can differentiate whether it's L5 radiculopathy or peroneal neuropathy causing foot drop. Another important cause for foot drop is the motor neuron disease ALS, which affects both upper motor neurons and the lower motor neurons. Right. This is all about the radiculopathy and roots. Now let's talk about the plexopathies. Plexopathy, a very important point here is we need to know whether it is the malignancy which is causing the lumbosacral plexopathy or is it because of the radiations which is causing the radiation induced plexopathies. So how do we differentiate the malignancy induced lumbosacral plexopathies or the radiation induced lumbar plexopathies? The pathogenesis, if we take the neoplasm, either it is because of the direct spread, example colorectal cancers can go to the lumbar plexus directly, or it could be a distant spread sacral plexus from the breast cancer. So it could be a direct spread like colorectal cancer involving the lumbar plexus, or a distant spread like breast cancer from sacral plexus. But for radiation, the pathogenesis is different. It is because of microvascular abnormalities causing fibrosis. So when there is a radiation induced lumbar plexopathy, it is because of the fibrosis due to microvascular abnormalities. The vascular supply is compromised. So that is one important point. Second is that the malignancies are usually unilateral. You see it only one side. But radiation induced plexopathies are bilateral. They can be seen on both sides. But one of the most important differentiating points between the malignancy-induced lumbar plexopathy and radiation-induced lumbar plexopathy is pain. We see pain in malignancy-induced lumbar plexopathies, whereas we don't see pain usually in the radiation-induced plexopathies. They are painless. The other differentiating point is that you have weakness and edema, the clinical features in malignancy-induced radiopathies, whereas we have fasciculations and myokemia in radiation-induced plexopathies. Then the malignancies usually affects the lower trunk, whereas radiation usually affects the upper trunk. So malignancy usually affects the lower trunk, whereas radiation usually affects the upper trunk. And of course, the neoplasm can be picked up by imaging, CT scan and MRI. Radiation-induced plexopathies cannot be picked up by imaging, CT or MRI. The other important causes for lumbosacral plexopathies are retroperitoneal hematoma. It is iatrogenic, medically induced complication because of giving heparin. It could be in more than the required therapeutic doses, and therefore the blood accumulates and then it can go and affect the lumbar plexus. So retroperitoneal hematoma. Then obstetric causes, delayed some problems during delivery can also cause the lumbar plexus involvement. Then injections. Generally when we give injections, we have to give on the lateral aspect of the back. If we give it on the medial aspect, then what happens, there could be a chance of injury to the lumbar plexus. And then traumatic, as I said, trauma is a less a common cause for lumbosacral plexus as compared to the brachial plexus, because lumbar plexus are deeply situated, unlike brachial plexus which are superficially situated. Second, lumbar plexus are present between the abdomen and the leg, which are not as much mobile as for brachial plexus, which is present between the neck and the hand, which keeps moving. And therefore trauma is less a cause for lumbar plexus as compared to the brachial plexus injury. So summarizing, all the causes of lumbar plexopathies: one, could be malignancy, it could be because of radiation, it could be because of retroperitoneal hematoma, it could be because of obstetrical causes, it could be because of parenteral injections when we give it medially as compared to the laterally, it could be traumatic pelvic fractures but they are less common, it could be because of psoas abscess, usually they present with swelling, fever, it could be because of amyloidosis, it could be because of sarcoidosis, it could be because of diabetes. Very important causes, diabetic radiculoplexopathies. In fact, diabetic amyotrophy is a well described term. Or it could be idiopathic radiculoplexus neuropathy. Sometimes surgery can cause, sometimes hip arthroplasty can cause, lithotomy position can cause, and as I said, foot drop because of ALS also can produce lumbosacral plexopathies. These are all the causes of the lumbosacral plexopathies. But the take-home message is the localization and differentiation of that. I emphasize two important clinical points when you approach lumbar plexopathies is the distinction between the femoral neuropathy versus radiculopathy. In femoral neuropathy, the muscles supplied by femoral nerve are involved, that is iliopsoas and knee extensors, but adductors are spared. Adductors in the thigh are spared because adductors are supplied by obturator nerve. Though both obturator nerve and femoral nerve are L2, L3, L4, the adductors are spared by a femoral nerve involvement because adductors are supplied by obturator nerve. One important clinical point. The other important clinical point is the foot drop. Foot drop could be because of common peroneal neuropathy or radiculopathy, but in common peroneal neuropathy, along with the foot drop, along with the extensor, there could be everter weakness, but inverter weakness is not there because inverters is supplied by tibialis posterior, supplied by tibial nerve. Another important clinical point. And the third important clinical point is to differentiate between L5 and S1. L5 is for dorsiflexion. So when the L5 is strong, they can walk on the heels. S1 is for plantar flexion, gastrocnemius. So if S1 is strong, they can walk on the toes. So if the person is not able to walk on heels, it is L5 radiculopathy. If the person is not able to walk on toes, that means it is S1 radiculopathy. So if you go in a methodical step-by-step approach, it is very easy to appreciate lumbar plexus and localize it. I've enjoyed giving the lecture and I hope you have also enjoyed listening to my lecture. If you have liked it, put a thumbs up on my YouTube channel. and you can give your suggestions also. I'll be very happy to reply to your suggestions and comments. Please like and subscribe my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. Thank you. Bye.